I think we're all ready to get started here. It's just a couple of minutes after the hour. The team here, Sundays, Michael, Adam, we're all here to help with the logistics and the support for today's webinar. And I want to just welcome everybody to our Friday call here. Um, and, um, and we're excited to be here today with our colleagues from AHRQ. This conversation started, I think, maybe 6-8 months ago to try to involve some of the great work that they're doing and really bring it to the large community and large and growing community within the NIC. And we'll talk a little bit more about that as we go forward. But I'm Daniel Stein. I'm your host today. And I'll be saying a few words to get us started here, a little bit of background, and then pretty quickly we'll dive right into the presentation. So Mike, if you advance, please. Thank you. So I probably don't need to say much about Zoom or online housekeeping or etiquette, but please, for whatever reason, if you could mute your mic. If you've got background noise on, I think that will be helpful. If you've joined by phone, you can change your phone number to your name so we can see you speaking as well. And we do have some opportunities during the call today to hear from you. You can always add your comments in the chat room. You can raise your hand to speak, and we'll also be providing some time for some questions as we go forward. The event itself will be recorded, I mentioned earlier, and it will be posted very quickly onto the hub. And we are also, as of last week, we started live streaming this. So for those of you who are on your phone, are not able to be in front of a computer or can't get through the firewalls, you can find us on youtube.com/user/stewards of change. So that's youtube.com/user/stewards of change. And that should allow you to see the slides. Those will also be posted on the site afterwards, along with the video for that. And Mike, there's a little bit of scratchy background noise there. So if you can just check to see who that is, that'd be great. As I mentioned today, we will be spending a little time getting acquainted with some of the wonderful work that AHRQ is doing, and undoubtedly will not have enough time to go into all of the both interesting and relevant, applicable kinds of topics that we'll want to share with you. As I said earlier, I got to meet folks at AHRQ. Actually it was at a HIMSS conference. I met the director, and we started chatting. And my background is a lot in the social and human services side. And it was surprising to me. I mean, I'd heard the name of it, I really didn't know what AHRQ had done and was doing. And so the more I sort of spoke with people and looked at it, I was delighted and excited about the depth and the variety of information that was a well-kept secret to me, and I suspected to many of my colleagues on the social and human services side of the universe. So it made sense, given the data-driven world that we're all living in, to provide an opportunity for us to get acquainted with the great work that AHRQ was doing. And in particular, at that time, Stewards of Change, the NIC had just finished a playbook on opioid prevention. And we were in conversation, again, with some folks from AHRQ who were doing related work. And so it was a very important topic, again, to recognize and to sort of discover the new world that was already there. About some of the work that was going on with opioids. And at that time, pre-COVID, that was the biggest thing happening in terms of affecting people's lives, affecting systems, affecting government. The number of people who were getting injured or dying from that was astronomical. And the issues were top of mind, front page. Unfortunately, it's been subsumed by something even larger. It goes for without even saying, the magnitude, the scope, and the spread of this is enormous. But opioids is still a very important topic and affects many, many people. And as we'll probably hear, the implications of COVID on that, on substance use disorder will only probably expand along with mental health and behavioral health challenges that people face. So it's a very timely opportunity to learn more about that and again, refocus on a topic that is of great importance to people. So if you could advance, Mike, please. We have, as I said, we've been holding Friday webinars for since August. So it's been a great opportunity to really cover a lot of different territories across multiple different domains, from health to human services to public safety to education. And so we're excited, again, to bring today's webinar to the table. We have webinars scheduled for the rest of May, and a couple of them are up here next week. We have one from Bright Hive that's doing some really interesting work on data trusts, focused on workforce and education. That's a really unique model. And then the week after that, we'll be focusing in on something we call Project Unify, which is a project of the National Interoperability Collaborative, looking at actually building out a cross-domain demonstration project on how you actually share information and get results from that. And then there will be some other sessions scheduled both on the 29th and then after Memorial Day. And if you're on the newsletter, you've seen those announcements. If you're not, please sign up at the NIC and we'll torture your mailbox with those announcements so you don't miss one. If you can advance one more, thanks. So just a couple of quick polls here. It's nice to kind of see what areas people focus on. And so we divide the world into 6 domains. And Mike, if you can launch that first poll and just give us a sense of what your main focus area is. Is it human services, public health, education, public safety, healthcare/healthcare IT, emergency medical response, or something other that we haven't captured? And we know this is a sort of a summary of many different domains. So go ahead, please, and submit your answers. We'll shoot for a good statistical representation for our research colleagues with us here. And in just a couple minutes, Mike, as soon as we kind of get to a critical number here, we'll go ahead and show those results. You can kind of do
we've
it.
got, we're at about 60%. We usually get to about 65, 70%, so we're getting close. Probably last call for responses.
The horses are coming to the end of the track. Here we go. You call it whenever, Mike.
Okay. Here we go. Share results.
The big reveal. So great. Good representation from human services. Public health is in the lead here. I imagine people organize themselves in different ways. Education, excellent. Healthcare, IT, and other. Public safety, I suspect I know who that is. We keep encouraging public safety to come to the calls. We got to find the right way in. So Paul, we're calling you out to help get us more people in there, and then emergency medical response. So just to give you a sense, especially our presenters, we want to give you a sense of kind of the breadth of people here. And then one other quick poll we're going to do on the location. So if you can put that one up as well, and we'll run through that quickly. Where are you guys from? I don't know if we had an other on that or extraterrestrial, but I'm sure people would choose that one just for fun. Yeah, we did not include Canada. We definitely have to include Canada next time, sorry. Michael, you should have picked that one up.
Yeah, the 51st state. Haha. I can say that because I have relatives in Canada. All right, we're at up to 75%. Okay, last call.
Okay, let's just get a sense of it.
Midwest representing today.
Excellent, great. We've got the country covered, and the other looks like it's probably our Canadian friends. And I did see folks from other places come. I think I saw someone from Egypt, and that's Mountain West. Where's that?
Actually, New York City is the 51st state.
Oh, that's right. Thank you, Tom. Right. Us out on Long Island would agree with that. So thank you. So we got a good representation across the country, a pretty diverse group of folks coming with different perspectives. I'm just going to spend a couple more minutes kind of giving a background. I know there's a lot of new people here to the call. So folks who have been on calls previously, you've seen this, but I want to just to give you a sense of how this is coming to us here. So a couple of years ago, we developed this thing called the National Interoperability Collaborative. And the idea behind that very simply was there's a lot of great work happening in lots of different domains. And we define a domain sort of as human services, public health. But we didn't see as much interaction or integration between them. And each of the domains and programs and sectors within those are working on many of the same problems and coming up with solutions and innovations that are not necessarily making it across the transom. And so one of the thoughts we had as we've been focusing on interoperability for many years is how do we facilitate that? How do we really intentionally bring the lessons learned, the challenges, the replicable tools and models to other domains? And obviously that was driven in part by opioids as a way to really demonstrate that for the first time, I think in a very broad way, the importance of that because it affects all these domains. But now, of course, with COVID, this is even more important that we're thinking across the domains and how people and organizations, institutions are affected by that. So, so we wrote a paper for HIMSS that's available on the website if you have more interest in that, and that's a driving force for the work we've done. A lot of this work has been supported by the Kresge Foundation, so I want to call out and say thank you to them for supporting, having the vision and the resources to support this cross-domain work. So thanks, David, and the folks from Kresge Foundation and our partners there. So move forward. So this is just a copy of the opioid playbook. I've mentioned this already. It looks at very actionable plays. And as I said, this is how we originally got started talking with AHRQ on this work. So next slide, please. And there you go. This is, I think, the last slide here. So just to put this work in the context of a slightly larger context, as I mentioned before, looking at the world of interoperability, or the lack of interoperability, depending on what perspective you come to it from. One of the things we strive to do is really focus on where the proverbial puck is headed. And our friends from Detroit, Michigan last week pointed out that Wayne Gretzky's from Detroit, so I just want to mention that, and I knew that. But that we are thinking about, while we're in the midst of this crisis now, and it's critically important, all hands on deck, that we want to be thinking about the future. We want to be thinking about where are we going to be in 9 months? What are the kinds of challenges and questions will we be having to address? And what will we have learned between now and then that could actually be actionable? We may be able to take advantage of this crisis, however hackneyed that phrase is to provide actionable recommendations, actually do something that could actually change the trajectory. How do we connect services and systems, learn from one another, and maybe provide the kind of integrated care, the integrated approaches to whole person-centered care. And so we propose a national action agenda, and we'll be working on that over the next 9 months, and culminating in a symposium, an in-person symposium that we're actually planning to bring people together around that in January of 2021. And so for those of you who are interested in learning more about that or learning on the other things, there's a group on the site here. There's a link to it, the Nick site, signed up for it. Go ahead and sign up, email us, and we're really looking for broad cross-sector, cross-domain participation in this work in order to really fashion something that is tangible and reflective of where the industry is right now. And so, so I just want to leave you with that thought and move forward to the next slide, Mike. As there's our handles and stuff like that. This will all be in the presentation. Go forward. One more. And now to come to the purpose of today's webinar, which is really looking at AHRQ's work and really bringing evidence into practice with a focus on opioids. And so we have 3 wonderful presenters today. If you advance a little bit, one more slide. There you go. So Elizabeth Cato will be kicking this off for us in just a moment, providing some context. Suchitra will be providing more important information on evidence-based practices, and then Roland will get into more of the digital elements of it and the technical elements of it. Please keep your comments coming through the chat box. If you have comments or statements that you want to make, of course, put those in there. We will post those to the site, or you could post to the site directly if you'd like. We probably won't have time to address all the questions today, but we'll want to come back afterwards and engage in some conversation on the NIC Hub for questions or comments that you want to make. And so with that, thank you for your attention on that. I'm going to turn it back now to Elizabeth to get us started on the presentation part. Thank you. Elizabeth.
Thank you. Hello, my name is Elizabeth Cato, and I'm a medical officer at the Center for Evidence and Practice Improvement at the Agency for Healthcare Research and Quality. And I'd like to thank the National Interoperability Collaborative and Daniel for setting up this opportunity for us to speak to you today. I'd also like to thank everyone listening for taking time out of your busy Friday to join us. Next slide. So we have, the three of us have no conflicts of interest, and this report should not be construed as an official position of AHRQ or of the U.S. Department of Health and Human Services. Next slide. So I guess we have a poll here.
There you go.
Let's see. Okay. Yes. So just so you have a sense of who we're talking to, if people wouldn't mind answering what is their primary work field or sector, and you can pick more than one. And I'm guessing that Sandhya, you'll call a halt when enough people have entered.
It's Michael. I'm running the.
Or Michael? Okay.
Yep, but we're at 66, so that's usually where we sort of reach the capacity. So last call for any more replies.
Question is, what end do you want, Elizabeth?
Huh?
What end do you want? I'm kidding.
Yeah, I think whenever the curve starts leveling off. So great. Okay, interesting. So a lot of nonprofit. That's great, but pretty good distribution actually across clinical medicine research, federal and state and local government, private sector, and other. Terrific. So we should have lots of different perspectives and joining the conversation. Next slide. So one of the initial catalysts of the opioid epidemic was an upsurge in opioid prescribing based on the assertion that opioids are a safe and effective treatment for chronic pain. And I was actually in medical school at the beginning of the upsurge, and I remember lectures about how opioids were underprescribed because doctors had foolish old-fashioned notions that they were dangerous, when in fact the pain receptors would soak up all the opioids, and so there was no risk of addiction if someone had pain. And we were told that it was really time to stop limiting the use of opioids to cancer and palliative care, and to use the blessings of opioids to eliminate all pain. And back then, those were really the days before the concept of evidence-based medicine became widespread. And so conviction and a single footnote really carried a lot of weight at that time. And as we saw, prescriptions for opioids increased dramatically, peaking in 2012 at more than 255 million a year, with a prescribing rate of 81.3 prescriptions per 100 people in the US. And as opioids prescribing rose, so did deaths from opioid overdose. And then we saw a further rise due to a surge in heroin and fentanyl. Next slide. So as overdose deaths increased, there was a series of policy, payment, and guideline shifts to try to bring down the sheer volume of pills prescribed. And as you can see from this graph, opioid prescribing has actually decreased over the past 5 years. But this has created its own problem. As clinicians and patients struggle to figure out how to safely treat pain, what all the options are, who these different options work best for, and also what is simply what is covered and what is available. So I think we can say that both sides of the opioid crisis, both the initial embrace of opioids without solid evidence of the balance of benefit and harm, and also the dilemma we're currently facing of pain management without opioids, could have been avoided in some part at least if we had been better at moving evidence into practice. And so that's what we're going to be talking about today. Next slide. The Agency for Healthcare Research and Quality, or AHRQ, is part of the Department of Health and Human Services, and AHRQ's mission is to produce evidence that makes healthcare safer, higher quality, more accessible, more equitable, and more affordable, and then to work with Health and Human Services and other partners, both inside the government and outside, to make sure that the evidence is understood and used. Next slide. So you could say that, really AHRQ is in the business of moving evidence into practice. I think there's a widespread assumption that scientists do research and then automatically all doctors have the information in their heads and can use it. Certainly my husband, who's an economist, seems to think it works that way. He says, well, doesn't my doctor simply know it? But in fact, there's really a long process between that study and making sure that evidence is acted on in ways that improve health outcomes. And as we've seen with the initial promotion of opioid prescribing, single studies can be very misleading. So to really have confidence in a research finding, we need to look at all of the studies to consider their size, their design, how they ask the questions, how are they conducted, and how they all agree and disagree. And by synthesizing all the evidence for a specific question, we can create a more accurate and stable view of whether a treatment is effective and what the actual balance of benefit and harm truly is. However, even evidence synthesis by itself is not enough to get the evidence into practice. Evidence synthesis tells us what studies found, but not what clinicians should do. So moving along the arc there, to make the evidence operational, it needs to be turned into clinical practice guidelines and also into policy and coverage decisions. The guidelines say, what clinicians should do, and coverage decisions tell us what will be supported and what will be paid for. And even then, these policies and guidelines may sit on a shelf unless steps are taken to integrate them into practice through things like clinical decision support, program implementation, and practice change. Only then can the information that is gained from clinical research actually improve health outcomes. Next slide, please. So today, we're going to be talking about just 2 steps along that path. Oops, sorry, back one. Thanks. So today we're going to be talking about just 2 steps along that path where AHRQ has been working to ensure that evidence is used to improve patient outcomes related to the opioid crisis. So now I'm going to, and those are evidence synthesis and then clinical decision support. So now I'm going to turn the presentation over to my colleague, Suchitra Iyer, to talk about evidence synthesis. Next slide.
Thanks, Elizabeth. Thank you to the NIC for this kind invitation and for the opportunity to share some of the work that AHRQ has been supporting. So I work with the Evidence-Based Practice Center program within the Center for Evidence and Practice Improvement. Next slide, please. So I thought I'd start with this quote by David Sackett, who's considered one of the fathers of evidence-based medicine. He defines evidence-based medicine as a conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. Next slide, please. Oh, I'm sorry. I think there's a slight delay, and maybe we should take this poll now.
Excellent.
Okay, final few votes are coming in. We'll call it in about 10 seconds.
Okay, so it looks like there's quite a lot of people who are somewhat and very familiar with it. And for those of you who are not, I hope that this talk will serve as a bit of a primer and will encourage you to go and find out more. Next slide, please. So as Elizabeth alluded, our job is to take the current evidence which is generated by researchers on topics related to healthcare quality and patient safety, and to put it in the hands of doctors and nurses and policymakers who are on the front line of decision making and improving care. The systematic review that I'm going to spend a lot of time talking about is our core product, and that serves as this bridge between research and practice. Next slide, please. So in the next few minutes, I'll describe what a systematic review is, describe how a systematic review is created at AHRQ, and walk you through a few examples from our recent reviews on treatments for chronic pain. Next slide, please. So what is a systematic review? It is one good source of evidence. It summarizes the existing published literature to answer predetermined set of questions that are focused. It uses explicit methods to identify, select, appraise, and summarize results from similar but separate studies. What a systematic review is not is it doesn't involve new primary research. So Henry Poincaré has said that science is built up of facts as a house is built of stones, but an accumulation of facts is no more a science than a heap of stones is a house. Next slide, please. That's relevant because similarly, systematic reviews are more than just a collection of individual journal articles. You have to make sense of the journal articles that make up a systematic review. Next click, please. So it involves a systematic search of many databases of scientific literature. You have to look for sources of bias in the individual studies and assess their quality. A decision is then made whether the studies are similar enough to be pooled quantitatively or whether a qualitative synthesis is more appropriate. An indication of the strength of evidence, which is a reflection of the confidence in the findings. Is the evidence robust, or is it indicated by just a very few studies, and does it lend some equivocal results to the situation? The identification of important information gaps. And finally, a discussion of how applicable the findings from the studies are to studies of other populations. Next slide, please. So a systematic review tells you with a certain level of certainty whether something works, whether it's harmful. Is one drug, device, or procedure better than the other? Is it more harmful than the other? Or is there no difference between the two? Sometimes we still don't know what works, but it's still helpful to capture and relay this information as an evidence gap so that it can be used for strategic planning related to future research. Next slide, please. Now, as you may imagine, it's difficult to keep up with the ever-burgeoning body of the literature, and there are new publications every day. Systematic reviews are a way to inform providers and healthcare policymakers about the state of the science. These could be in the form, the systematic reviews then inform a number of resources, whether they are targeted summaries, clinical practice guidelines, or education resources. And this is a time to remind you that systematic reviews themselves do not make any recommendations. Next slide, please. So this is a slide courtesy the CDC that shows the rise in overdose deaths in the US leading to the current opioid crisis. Since opioid prescribing practices are partly to blame for it, it's important to consider other treatments where possible. Next slide, please. So AHRQ recently completed 3 systematic reviews on the treatments of chronic pain. These were completed by our Evidence-Based Practice Center in Oregon and are now available on our website. Next click, please. So we look at opioid treatments So there are 3 separate reports, and they define chronic pain as pain that lasts 3 to 6 months or beyond the time of normal tissue healing. This report does not include treatment of cancer pain or acute pain conditions like fracture or tooth extraction. Next slide, please. So the first report looks at opioid treatments. Oh, I'm sorry, I just got distracted by the screen. Okay. So the first report on opioid treatments includes studies that looks at outcomes in patients that have given opioids compared to placebo, other opioids, non-opioid drugs, or non-invasive drugs, or non-invasive non-pharmacologic therapies for chronic pain. The second one looks at non-opioid drugs for chronic pain, such as acetaminophen, NSAIDs like ibuprofen, skeletal muscle relaxants, benzodiazepines, anticonvulsants, and cannabis. And these are compared again to placebo or to between each other across different families of drugs. The third report looks at non-invasive non-pharmacologic therapies, and these include things like exercise, behavioral therapy, relaxation, meditation, virtual reality, acupuncture, and manual modalities such as massage, manipulation, transcutaneous electrical nerve stimulation, braces, traction, heat, and cold. So there's quite a large range in there, and the report is several hundred pages long. Next slide, please. So the reports focus on outcomes that are stakeholder prioritized and patient-centered. So all reports assess pain, function, satisfaction with the pain relief, quality of life, including secondary measures such as sleep and mood, harms, side effects, and whether it leads to or reduces risk of substance use disorder. Not only did the authors look at the outcomes in the short term from 1 to 6 months, but they also looked at how people felt in the intermediate term from 6 to 12 months, and in the long term, which is times more than 1 year. Some other outcomes that were looked at, especially in the drug studies, were withdrawal, risk of misuse, overdose, persistent opioid use, and opioid prescribing rates. Next slide, please. So the details of all the various comparisons and findings are available on our reports on the AHRQ website. I will just walk you through a few examples of the ways in which the data are presented as a sort of a orientation. So this is a forest plot. It's a graphical representation of results from similar studies. And in this case, these are studies that compare people who took opioids to those who took non-opioid drugs for chronic pain, and looks at their ability to function in the short term. The squares represent results from individual studies, and the diamond below is a summary statistic that averages the effects of the preceding squares. These studies are clustered by drug family. So there are opioids that are compared to gabapentinoids, to NSAIDs, or the antidepressant nortriptyline. Next slide, please. This is a summary table that shows findings across multiple comparisons that are listed on the leftmost column. And it also tells you how much it improves pain and function, and whether the effect is sustained over time. And the small denotes the fact that there was a small difference in pain between the two groups. None refers to no difference between groups. And where there are no studies or no evidence, it's called out with the shading. The plus refers to our confidence in the findings. So 1+ indicates low confidence, 2+ is a moderate level of confidence, and 3+ is high confidence. So the findings from the forest plot 1 that I showed you earlier comparing opioids and non-opioids are under short-term function. Next click, please. Right there. So all those studies that inform that forest plot actually is summarized in this one cell here. So this is where it compares to everything else, the other comparisons. Next slide, please. So here is another example from our report on non-invasive, non-pharmacologic treatments. This is a forest plot that depicts the effects of treatment with exercise versus placebo in people with low back pain. And the studies in this case are clustered by the duration of follow-up. So the top tier has short-term studies, the middle tier has intermediate-term studies, and at the bottom you'll see there's been only one study that reports on long-term follow-up. Next slide, please. So this again is a summary table that presents results from other treatment comparisons. On the left column, you'll see psychological interventions, mostly cognitive behavioral therapy, yoga, mindfulness practices, and multidisciplinary rehab. Next click, please. So again, this is where the data from the previous forest plot sits. It shows how much improvement there is in pain and function and the durability of the effect over time and the confidence in our findings.
Suchi, can I just interrupt for 1 second?
Sure.
Go back 1 second here. It looks like, I just want to clarify for both myself and maybe others, in terms of the way the data is presented here, I'm assuming this is a fairly standard way of the way you would be looking at the effects of different interventions. And are these all, especially on the plus side, are they all statistically oriented? Is there a qualitative element to this, or how are those actual results sort of addressed or identified?
So there is a qualitative description. There's a narrative description of the results, and there's a very detailed discussion section which talks about these results in the context of what is already known, in the context of current guidelines, where there are research gaps, what conclusions are not applicable, because a lot of these studies included, a certain population of patients that don't necessarily resemble others. So there's quite a lot of narrative description, as well as a detailed description of the systematic review process.
And Suchi, do you mind if I actually jump in a minute?
Yep.
Yeah, sorry, I was just looking at the comment in the box, which I think may have prompted that about effect size. And actually, what the review did was to look at the standardized pain assessments and function assessment tools, as I recall, and then create a standardized mean effect where they kind of brought all those different scales into a single scale. And what was it? 20% difference was small, 20 to 50. I'm sorry, it's been a while since I've read these, but it was so it's kind of based on statistics and standardized tools, and then standardizing the different tools so that it's so that it's sort of a fair comparison. Was that a good statement, Suchi?
Yes, that's right. And also where applicable, they also looked at MCIDs, which is minimal clinical important differences. Mm. So with pain being so subjective, that is difficult. So even though there may be a small difference in pain in response to one of the treatments, we still reported it as small, because it's hard to say what that small difference in pain means to a patient. It can make, because of the subjectivity of the pain, we did talk about MCIDs and the lack of it for some of the outcome measures, but largely everything is reported based on standardized measures, scales.
So when it comes to, just to go a little bit further, so when it comes to something like pain, which is subjective to every individual, the results are based on a scale, but it's relative to the individual's response to that scale, from whatever it might be, 1 to 10 or whatever.
Yeah, so I saw the patient would fill out a questionnaire depending on what scale was used. They would say that the improvement was, say they had an original pain at level 5, and then if it was level 4, then that would be a 1-point difference, and that would count as a small difference.
Mm-hmm. Okay, great.
Okay, so next slide, please. So as you probably noticed, there were a lot of gray boxes where there were no evidence, and systematic reviews are inherently limited by what is in the published literature. Since there were many, can you hear me? Because I'm getting some sort of feedback that says low bandwidth. Can you hear me?
Yes.
Okay.
We can hear you.
Yes, we hear you.
Okay. Okay. So, so the gray boxes in the summary tables were indicative of the fact that many times there is no evidence, or either due to the fact that there are no studies or very few studies, as was the case for long-term effectiveness of opioids. Many of the non-opioid drugs that help patients with pain, but with a variable response to the different drug classes, it suggests that we have to be careful when considering patient characteristics before selecting a drug. But studies rarely reported analyses based on patient characteristics. A lot of studies don't include people with concurrent health conditions like diabetes, kidney disease, and obesity, which is not really a reflective of real-world conditions. Next slide, please. So we recognize that the absence of evidence is not evidence of absence, and that clinical decision-making needs to consider more than just the available evidence. Yes, evidence is one piece of it, but in addition, one needs to consider the values and preferences of patients and their physicians, as well as resources such as evidence-based clinical practice guidelines and decision support tools that you're going to hear about next from my colleague Roland. Resources are also education and communication and technology that enable the implementation of evidence into practice. And with that, I open this up to any questions. Of course, Daniel, I'll let you decide if you want to take questions
Sure.
now, or let Roland speak in case people drop off early.
Let's see if there's a few questions right now that are top of mind for folks. I can read some from the chat. In particular, one just came in, and you can see them from the chat as well. Some of them may be relevant as well. So one from Kaylee just came in and says, what does sort of patient characteristics include? What about the embedded bias in the administration of pain medications? For instance, research demonstrates that some doctors are still believe black and white patients feel pain differently.
Yeah, and that's interesting. But for the purposes of this review, the patient characteristics involve things like the severity of pain. How much pain do the patients have to start out with? We looked at sex differences as well as differences, age-related differences. Older people may feel pain, be more sensitive to pain. Whether a patient has had opioids before, has there been sensitization already? That could also affect the way in which they react to medication.
And you mind if I jump in?
Please.
Yeah, please do, Elizabeth.
Yeah, I was gonna say, this is actually, it's a great question, and it actually, I think, highlights the importance of using evidence systematically and having guidelines, because when you have variability and subjectivity in how care is delivered, that's when bias gets magnified. And there have been some really interesting studies coming out of prostate cancer treatment and also heart failure management, that when you have clinical trials that really strictly standardize the care of treatment, some of those racial disparities in outcomes go away. So, if we can actually have a clearer idea about what really works, what the best treatments are, how it should be delivered, and make sure that the best treatment is being delivered across the board, that's actually one way to get to help to overcome bias and have better outcomes for everybody.
I would like to ask a question that goes back to one I put in the chat box, that you're looking at these comparisons and they're showing very small to moderate effect sizes and moderate ranges dramatically. What do you believe, based on the evidence that was presented through the literature you reviewed, accounts for the remainder of the variance not accounted for by these?
Elizabeth, do you want to take that? I had some trouble hearing it.
Sure. Well, you know, it's always hard to sort of measure unmeasured confounders. So if we knew what that was, we would measure it and we would know it. So I'd really just be speculating. But I think there's clearly a huge range of possible things that would have an effect, all the way from in the social context, but also on the one side through comorbidities, through the patient-doctor relationship, through psychological factors, through genetic factors. So I think there's definitely a huge amount of variation, and we need so much more research to really understand why people respond so differently to pain and to treatments.
There's a question from Kristen McGarty.
Hi.
Hey, Kristen. Hi. Where are you from?
Speaking from a disability advocacy perspective, I have seen policymakers use this review, and they don't always delve into the qualifiers. Sometimes they just jump straight to the summary where it says here, opioids are not superior for chronic pain, and they set hard limits for literally every condition that isn't cancer, even when benefits do outweigh risk. And we do have new evidence that these limits are doing harm to people with disabilities. Is AHRQ intending to review that evidence as well?
Sushi, do you want me to take that one?
Sure. I'm having some trouble hearing, so but if you can repeat it, I could possibly take it. But go ahead, Elizabeth.
Sure. Yeah, no question that I think as I said at the beginning, that we're seeing, I think, with the whole opioid crisis, two failures in terms of moving evidence into practice. On the beginning of it, it was using opioids when the evidence was in context where the evidence was perhaps not strong and where the balance of benefit and harm was not understood. On the other hand, we've seen the withdrawal of opioids, again, without really understanding where they are needed and what the best way to do that is. And the CDC actually last spring, so it'd be about a year ago, came out with a paper stating this and saying, our guidelines were about starting opioids. They were not about stopping opioids. And then last summer, I think July it was, HHS came out with a unified statement about how to approach tapering and continuation. And I think the guidance has become much clearer about how this should be handled. So it's not really an evidence question. It's really, it's farther down on that chain of what do you do with the evidence? And again, I think it underlies how far we have to go in really having a smooth arc of moving research knowledge into practice that helps patient outcomes. And we need to spend, I think, a lot as a society, we think a lot more about getting that basic information, and we don't spend nearly as much time and thought and resources on how do we put it into practice. So it's, yeah, great question, and it's something we're always working on. And we'll get to today.
There is the evidence is times that there should be studied.
Having a little trouble hearing you.
Oh, I was just saying that there is evidence, and the evidence is of harm, and these harms need to be studied.
Right. Yes, and they are being studied, and things like some of our practice improvement measures. Actually, we're in the middle of launching a three-pronged project looking at the management of opioids in older adults. And a lot of that really is focusing around the dilemma of how do you manage pain in older adults? How do you fit opioids into all the other pain management strategies, given the complication of frailty, comorbidities, mobility restrictions, et cetera. So yeah, it's a very it's a problem, and it's something that we really need to study and we're working on.
Great, thanks. I think let's turn to Roland. We have time after Roland's presentation for more questions as well. And so I know that some of them are coming in on the chat, so keep them coming in and or bring them back when we move to the next section. Roland.
Great. I just want to remind you, of course, I had the, being from the technology end, I had the technology curse, right? So I was not able to log into the Zoom website. Everyone else was able to do so. So if I get to the slide where you're doing the surveys, you need to let me know also, please.
You bet. We will do. Thank you.
All right. Yep. Good afternoon, or good morning, I guess, where you are, depending where you are in the country. Thank you for the opportunity to present on the work that the Digital Health Research Division has produced using support. And in particular, I'm going to talk about the pain management summary. But before, and I remember from the first survey, I just want to let people know my background is actually in public health. I have 18 years of public health from the Midwest at the State Department of Health. So I'm coming more from a public health background, recently moved into clinical decision support. I'd like to briefly talk about the Digital Healthcare Research Division. Its mission is to produce and disseminate evidence about how the digital healthcare ecosystem can advance quality, safety, and effectiveness of healthcare for patients and their families. And Elizabeth and Suchi both talked about that as being part of the mission of AHRQ and their work as well. One of the efforts was to examine the feasibility of using clinical decision support to reduce the time required to move from the production of this evidence, effective evidence, and moving that evidence into clinical practice. It takes a long time for that to happen. Next slide, please.
Roland, we have the poll slide here that says, have you ever worked on a health IT project?
Oh, okay, great. I'll wait for you then.
Okay, so if we'll launch that, and then there's either a yes or a no answer. So that should go pretty quick. And Mike will reveal the answers in just a moment.
So typical computer question, right? Yes or no?
It's pre-AI.
Okay, folks, if you're anywhere near a keyboard, last call for responses. We're about halfway through. Give you about 10 or 15 more seconds.
All right, let's go ahead and post it. So Roland, 46% said yes and 54% said no.
Oh, great. Okay. So I hit the right target right in the middle for the presentation, so that's good to know.
Perfect.
So we should be on the objective slide right now, is that correct?
Yes, we are.
Great. All right. So the problem, looking at this, is that after the evidence is produced and published, historically it takes years before this evidence is incorporated into practice. And Elizabeth talked about that, and Suchi as well. In the current system, additionally, each healthcare system or practice has to take the narrative evidence and translate this narrative into a business process for the clinical workflow. So you're talking about thousands of different places that are trying to convert this information from the narrative into their workflow. And I'm going to talk about this translation more in a slide later in the presentation. The primary objective of this section then is the presentation to discuss how clinical decision support, or CDS as you'll see used in the slides as well, is being used to reduce the time and the resources required to move evidence into practice. The remaining objectives in the list are all really relate to moving the evidence into practice and to support this primary objective. And I'll explain the use of the standards-based CDS solution in the context of the 5 rights. On the next, that'll be part of the, this isn't to move, but it's on the next slide. And the effort required if each health system or practice develop their own CDS. And then relate how these changes potentially impact the time required for dissemination. And then finally, I'm going to describe how the clinical quality language, or CQL, is used to produce this standards-based CDS solution and why CQL is so important. Next slide, please. So the 5 rights is shown in this slide. And it was originally published as in the singular, and you'll notice by Jerry Oshenoff and group in 2005. However, as people have discussed this more, the 5 rights might require multiple channels, multiple formats, and different audiences, et cetera, providing the same guidance in different ways and at different times, and it's likely to be more effective that way. So notice that the current slide is in the plural, so it is to the right people in the right format, or sorry, the right information to the right people in the right formats and channels at the right times. Fortunately, information is already plural, so I didn't have to change that one. Well, our study is to use clinical decision support artifacts to provide a solution that addresses these 5 right issues. Next slide, please. So here's a diagram of the life cycle steps that have really been discussed today. On the right-hand side there is a picture of a document. And this step is the collection of evidence that Dr. Iyer presented earlier. And notice that arrow then goes next to an expert, or really it's usually a group of experts that takes this information and translates it into a CDS artifact. So these are the tools or apps. These artifacts then, at least in our model, are published in the CDS repository, where a health system then, on the left-hand side in that circle you can see, can choose to download and use the artifact. Of course, this tool is used by the CDS community, where improvements can be made and built into improve the artifacts and can be then updated into the repository. And Elizabeth talked about this as well in, as evidence is moved into practice, we learn more about it, we can make improvements there. I just want to mention, though, the arrow that moves from the documents to the CDS artifacts contains a lot of additional steps that really aren't included in this diagram, but expanded on in the next slide, please. So this table is a description of the different levels or steps used in moving from a narrative evidence into or guidelines into an executable clinical decision support artifact that would be used in in a production environment. So an expert or experts then take the new evidence and produce a semi-structured type of artifact or form from the guidelines itself. These are usually flow diagrams or decision trees. The guidelines may not include all the processes related to the local workflow or other common business practices. So there's likely to be some gaps in what the narrative evidence is producing and what needs to happen in practice. So that's another reason why you need experts to help look at this and fill in some of those gaps. The structured level is a standards-based compliance specification and logic and data model, actually, that represents the semi-structured recommendations. What's interesting about how we use this, and this is where I'll talk about CQL a little bit, the structured and coding logic is what we is used in our work for the clinical quality language, or CQL. And this language can be interpreted by multiple platforms to produce locally executable clinical decision support tools that can be used by an electronic health record production system. And I want to emphasize that the CQL will produce CDS in different EHR environments so that it is interoperable as well. Next slide, please. And I think we had a call-out box, right? Is that what's there now?
Yeah.
Okay, so the call-out box describes these steps and then moving from the narrative format to the computer executable tool that represents the new evidence or guideline. Next slide, please. Okay, for anyone interested, we do have an authoring tool on our website. You can write your own simple CQL using the CDS authoring tool. The tool has a link on the page, on this page, and there's also a tab on the AHRQ CDS webpage that's at the link for that one is on the question slide at the end of the section. Interesting, there are a few institutions that are using the authoring tool in graduate programs to introduce CDS to their students. And additionally, I just want to mention the CQL is part of the HL7 standards, and the tool uses the HL7 fire resource data model to help easily move data from the EHR and be able to use that. And I'll discuss that in a little bit more as well later in the presentation. Next slide, please. So why use clinical quality language? Well, CQL is robust and precise. I have down here as well the quality measures, which I really discussed as much today, but the focus on CQL is that it can link clinical decision support with quality measures, and CMS requires the use of CQL for representing this logic in the ECQM measures. CQL is also highly compatible with HL7 FHIR. It's flexible to the evolving standards and data representation, leverages the best practices and lessons learned from past standards. As I mentioned earlier, CQL provides a standards-based representation that can be interpreted by different EHR platforms. So it provides the interoperability and the ability then to share with multiple healthcare systems, regardless of the EHR platform that they're using. So again, this is going to help us move or disseminate that evidence into practice. Next slide,
well,
please.
let me just jump in here for one moment here. One of the benefits of this broad audience is you get a lot of diversity, but you also have some new folks to the table here. And without getting into a lot of detail, there's there's reference HL7 FHIR here, which in the healthcare community is very commonly known. Outside of that community, it is a little less known as a standard. You may want to just spend a minute just talking a little bit about that. As we look at sort of the cross-domain kinds of things, we've got a couple seconds just to reference that.
Yeah, that's good because I do talk about it again at the end. So It's a good point to bring in here. Thank you for that. The FHIR data resource is actually taking the information that is in an EHR, and then it just maps that to a kind of it's what everyone has agreed to say, here's what the data will look like in this interoperable FHIR resource. So it's a local code that's mapped to this data resource in HL7. So this first started as a pilot. It's moving forward now as part of the new Cures Act as well. It's in there based on the US CDI data set as well. So, but not all the information that's in the EHR is mapped to this FHIR data resource at this time. Just those, I would say it started off just as those ones that were needed for interoperability issues, and it's expanding more now. So when we first started this project, it was a lot more difficult to find some of this data. It's becoming easier to find a lot of it, but there's still a lot of it that has to be mapped by hand when you first do a project from the local code set to this FHIR resource as well. So really it's an interoperability method to get data from the EHR and be able to exchange it pretty seamlessly with other people who need that same information in a different format or in a different type of EHR system. Does that describe it all right?
Yeah, no, that's great. I just want to point out that over a couple of weeks ago, we had a very in-depth, well, a high-level overview from the Office of National Coordinator and some folks talking about HL7 and FHIR and FAST and some of the accelerators that many folks may be familiar with. And so that's recorded if you have interest in diving deeper into it. They did a terrific job really providing an overview of those, some of the core concepts that are going into building the technology and the semantic languages that are allowing systems to talk to one another. So there's been a lot of really good progress in that. So we'll, as you said, you can find that on the site, but we'll make a reference to it here as well. But no, thank you for providing that overview, and thank you for raising the question. Others, please go ahead and do that. Go ahead.
Super. So this is all great up top, talking about how great everything is. I'd like to show a use case then of actually implementing the narrative selection section up above, and the kind of formats and data standards we're talking about putting in place here. So this use case is for pain management summary for a provider. And I just thought it's a lot easier, I think, if I talk about the patient profile a little bit. So this is somebody with chronic back pain. They've had lower back pain for 11 years. Some of the conditions that contributed to that: female, 65 years old, has some moderate major depression, and then a pain severity score in the range of 0 to 10, and hers is at a 10. So next slide, please.
That slide that is the patient profile slide. So I think one more after that, right? There you go.
Okay. So here's the pain management summary. The summary then just what this tries to do is pull out the pertinent data about the patient and displays that information in one location, so the provider doesn't need to click back and forth through the different sections of the EHR to find this pain-related information for the patient. I'm just showing one section here. You have to be able to scroll down, but again, it's easier than trying to skip between all the different sections in the EHR. So this one is the pertinent medical history. It includes conditions associated with chronic pain and the risk factors for opioid-related harms. And you notice the red exclamation point is added if there's data that clinicians would consider to be important to know about. And you notice that there's one here on the risk factor section of the display. Well, and the next slide should show a little call-out box as well. So here there's also sections for pain assessments, historical pain-related treatments, and risk considerations, which all you have to do is scroll down to get to those, or you can link to them on this little box as well. That's usually on the left-hand corner. There's a link to the artifact directory at the top of this slide. And if you want to go to this directory and look at some of the artifacts, the link provides detail on the recommendations that were used to produce the summary. It has the details about the guideline itself, and a report of the results from the clinical pilot study of this artifact. And then halfway down on that section, there's a link to try the artifact itself with some synthetic pre-populated patient information. So if you want to see how this actually works in practice, it's a good place to go and see the different types of information that may be there. And then the next slide, please. So lessons learned. Our first step was really to determine if it was feasible to produce interoperable CDS and share these artifacts with others. So that was our major purpose of this type of work. And it's interesting that it has demonstrated that people were interested in using this summary. Now, they haven't necessarily used it directly as is. A lot of people have modified it for their use. But there have been more than one organization that has downloaded this and used the pain management summary itself. So it does show that the use of interoperable and standard-based artifacts are important to help get evidence out there and be able to use it at least faster and more conveniently than just looking at the evidence directly. We already talked about this FHIR resource mapping. This is where I was going to look at it again. And I just talked about, again, not all the data is mapped to FHIR, so some of the data that has to be mapped by hand still from the local codes. If the data is, sometimes with an app, you get data from the EHR as well as from outside data, outside of the EHR. So this is an issue that's come up, actually with the PDMP data, it's come up quite a bit. if you're grabbing this data and trying to bring it in, there's issues with the vendor in trying to reconcile that data that's brought in from outside and how that reconciliation process has to happen. So a lot of times we really don't, this data isn't really reconciled itself. It's just used within the app and then not added into the EHR. But it brings up a different issue then, is the data that was available when the physician was making the decision needs to be recorded someplace as evidence. And it's actually legally required to be there somewhere. So there's been some issues and different strategies then of how to store this snapshot in time within the patient's medical record someplace. Some people have decided to store it within the app, which causes some issues. And then there's issues of where to store it within the EHR itself, because you don't want it within the data source within the EHR. It has to be associated someplace that's not being incorporated as a data source itself, just a snapshot associated with that patient. So issues there as well. And again, these are issues regardless of the type of problem that you're looking at. I mean, these are problems that could occur for pain management or for other types of clinical decision support problems that you're looking at. Deduplicating data as well is an issue, so how you might do that has to be coordinated with the vendor. Also, understanding the context and use of the artifact is really important. So how this fits into the clinical workflow and what the local context is for how it's used. For for the pain management one, if you're talking about a group of primary care providers who only see pain patients periodically, the type of information and what might be displayed would be different from somebody who is a chronic pain specialist and may see the patient quite a bit and sees these types of issues quite often. So that context, again, is really important, how the app might be used or not used. We also heard conditions where people have used different types of apps, like in teaching institutions, where they have a lot more students that are involved versus people who have been in practice for long periods of time, and the types of alerts and information that's being displayed might be different in those two settings. So again, that context is really important. I think going back to the beginning of the objectives, I talked about all these major points and the why CQL is important and what interoperability will do for us. The one part that we are now working with is trying to get some demonstratable evidence about, is there a measurable decrease in time that it takes for this evidence to get into practice? And can we reduce the resources involved when, having multiple institutions then don't have to reinvent the same artifact each time they want to use it, and what that impact will be. That's brought us some interesting questions about trust of the data itself and the evidence, and also of the artifact development as well. So that's some new areas that we're working at also. And if we have time, I'll take some questions. I've also, on the next slide, I have the links to the CDS Connect website, and some links to just some funding opportunities as well, I believe. The pain management summary and the CDS initiative itself.
Thank you very much, Roland. We do have some questions that are here. I'm also wondering, Elizabeth, before we dive into the questions, if you have that one slide around kind of some of the other resources that AHRQ provides, that might provide the context for both specific questions for Roland and the other presenters, but also more broadly in terms of the applicability of AHRQ's work. Does that make sense to look at that?
Sure. I can go through those pretty quickly. Next slide, please. So, we've been talking about moving evidence into practice, and we talked about evidence synthesis and clinical decision support. But next slide. So AHRQ also does a lot of work farther down the slope on things like practice change and implementation. So I just want to call attention to two projects that we have. One is 6 Building Blocks, which helps practices to implement evidence-based treatment and management of opioids in their practice. And another is the MAT Playbook, which helps primary care practices to set up and integrate medication-assisted treatment for their patients who have opioid use disorder. Next slide. And of course, we're a funding agency, so I can't pass up an opportunity to just call attention to the fact that we're always looking for good research on healthcare services. So if you go to ahrq.gov/funding, you can see all the most recent funding announcements. Next slide. And just want to make sure that you know that everything that AHRQ is doing related to opioids, so that's the data and analytics from the Healthcare Cost and Utilization Project, the Medication Expenditure Panel Survey, all the evidence reviews and practice guidelines and other tools for implementing practice change. They're all here on www.ahrq.gov/opioids. So did that do it, Daniel?
Yeah, that's a great opening. We got about 10
Okay.
minutes for some questions and discussions. One of the things, I just asked one quick one and then certainly open it up for folks here. And there's been a couple in here. As we look at the resources and the methodologies and approaches that you guys are focused on now, I'm just wondering from a outside of the clinical healthcare side, what might be transferable or adaptable to, for instance, the human services side that's looking closely at social factors and social needs, social determinants. And is there any discussion within AHRQ around those topics, which have really kind of exploded in terms of their both awareness and interest there, that you can point to?
Yeah, actually, we just launched a big grant initiative around social determinants of health and connected care. And unfortunately, I'm not connected with those projects. So I'd have to get back to you with the exact links. But yes, that's definitely an area of very great interest. And we have a number of initiatives. Just I'm not personally involved in them, so I don't want to make any mistakes if I talk about them.
Sure. Well, we will probably ask you at least to put us in contact with folks and maybe schedule another call for folks who want to dive into that. I know it's an important topic for folks.
Absolutely. And the AHRQ website will have information about that.
Fantastic. Fantastic. Let me open it now for other questions or observations from folks who have been participating here. Time for a few. Feel free to unmute yourself or put the question in the box. There are a few in the chat box here.
Do you want me to just pick
Yeah.
them, or do you want to ask?
Oh, hi.
It took me a minute.
Can you hear me?
Oh, hi, Arlene.
Yeah, so this is Arlene Bierman from AHRQ, and thank all my colleagues for great presentations. I just wanted to give a little more information of some of the related work AHRQ is doing on the social determinants of health.
Great.
So we've funded 3 projects to integrate data on chronic disease, social determinants of health, and community services into dashboards for primary care practices so that they can better manage both high-risk people and high-risk communities and populations. So that's a whole innovative project. And as I was thinking, it might be something that this group would be interested in learning more about. In terms of pain management, we're working on developing an interoperable shared electronic care plan to get people all on the same page for people with multiple chronic conditions. And we're including chronic pain as one of those conditions. And we're including, community and social services in terms of linking to the care plan to get everybody on the same page. So we are doing quite a bit of work in that area.
This is Marcely Hancock. I have a question. This has been so encouraging to see how much work is going on and what's available and how we can participate or leverage the work you've done. For the people who are in the policy space, I'm curious about thoughts. Yeah, you mentioned that nobody gets paid or gets excited about implementing new improving the same old research or implementing research. And the strategies or the drivers for research is tenure, and it funds your program at the university or at your research institution. So what types of policy changes can provide the incentives that allow for researchers to be able to spend time implementing and refining what we already know is existing?
Arlene, do you want to take that one?
Do you want me to take that one? Yeah, so no,
That's more in your wheelhouse, I think.
It's a hard one.
So that's a big focus of AHRQ is implementing evidence into practice. And we have a series of implementation projects. And when we do them, we're trying to not only, improve practice and implement the evidence, but also learn how to do that better. And for example, we have a series of grants right now on addressing unhealthy alcohol use in clinical practice that's really aimed at integrating behavioral health and primary care. So yeah, and there's a whole, I think this is a time to really use the science of implementation and integrate it with quality improvement to really have a bigger impact in all of these practice improvement efforts.
Thank you, Arlene.
I agree, thank you.
And thank you, Marcely. So I have one other question, if no one else wants to jump in here, which is, how does, Arlene, this may be for you as well, which is, there are so many things happening across the federal government, programs, lots of initiatives, payment models, all this stuff that's happening. Is there a process by which other agencies are leveraging or resourcing what AHRQ is doing and being able to sort of cross-reference those things? Just thinking about programs that are looking for evidence. Is there a natural connection between those things for where those initiatives are happening?
Yes and no.
Okay.
We really do try, and we know that our evidence is being used across the federal government. Like, for example, the VA has picked up on work that we've done, as has CMS and CMMI. We work closely with HRSA. But is everything picked up? Probably not. Can we do a better job of it? Yes. So, but yes, it's something that we really try very hard to do. And also we have a number of cross-agency projects, and we participate in cross-agency committees. So for example, across the whole department, there's a big focus now on social determinants of health. And all of the federal agencies are sharing regularly the work they're doing in that space.
Oh, that's really encouraging. I appreciate that. And I'm glad to hear that work is going on, because it does touch so many different agencies and organizations. And I do, many of the participants here are working to integrate learning from sources into the projects that they're doing on the ground. Some of them are funded by CMMI or CMS or the Office of National Coordinator. So that sounds great. We just have a couple of minutes left here. I just want to point out, and I want to first of all thank you all for participating today. I know it's oftentimes very challenging to sort of reduce down what lifetime's worth of work or career's work, but I think you did a great job orienting us to a section of the work. And I will warn you that I'm going to ask you to come back and talk more about social determinant work. I'm sure the audience the participants will really want to hear more about that. So again, deepest appreciation for taking the time and all the fantastic preparations you have taken and taking time out of your day and spending another hour and a half on Zoom. So you can check that up to your frequent flyer point miles bank. Sundays has been showing a few slides about some things coming up. Next week, we have one on responsible data sharing using data trusts from Bright Hive. A lot of overlaps with that and the ability to actually share the information, generate results, and obviously generate evidence as well going forward. And we invite folks who are new to the meetings to come and participate. And then on the following week, on the 22nd, if you can advance one more time, this would actually be something that I would love to just really explore further with both the attendees here, as well as members from AHRQ that may be interested in. We're really looking at trying to develop a proof of concept that demonstrates the flow of information across and between organizations that are actually delivering services. And so there's been a proof of concept working. I think that your perspective on evidence and research on what works and how it can work would be of great value. And that's going to be on the 22nd. We'll be focusing a lot on the Project Unify and some of the sites that may be doing some work in that area around integrated care for kids and some other areas. And as part of that, we're trying to integrate into that some of the ONC's accelerator projects, Gravity, Da Vinci, Karen, and also ONC Fast. So come and participate. We're looking for more members to participate in these sort of quasi-formal Tiger teams to really advance this work. It's a good group. You can find more on the hub itself. And just go forward one more slide, I think. Yep, I want to again, special thanks to some of those folks who are participating in that proof of concept and have been participating in the hub. Iris, Alexandria Consulting, HS Link, and then Interoperability Institute. And for those of you who have a few moments, this is a link to a survey, and Sundays has put that up. We're always trying to sort of improve what we do and what we offer out to the community. And as I said, we will be doing more of these going throughout the rest of the year, leading up to an event where hopefully we'll be able to synthesize and bring lots of this good learning together. And with that, please take a minute if you can take that survey. It's only a quick 10 questions. And as a last point here is if you haven't joined the NIC, here's the URL for it. There's a lot of material and work, again, across multiple domains that are of interest to participants here. And you'll, as you sign up, as I said, you'll be alerted to newsletter and some of the other events that are happening here. We will be, we're not going to be sending out the slides. So if you go to the hub, you'll see the link to this particular presentation. The video will be available, the slides will be available, and there'll be a chat box, and we'll do a short little blog. And for those of you who have more in-depth questions and conversations, there is a discussion area there. And I would invite you to post your questions. And I think some of our colleagues from AHRQ said that they would be willing to sort of engage in some conversation. It may take a little more thought, a little more responsiveness and reference to other materials. So to that, thanks everyone for your participation today. Stay well, stay healthy, and we'll be back here next week. So you're all invited to join. Have a weekend. Have a good weekend at that. So thanks so much for all, and we're going to sign off. And thanks for all help.